Immunodeficiency is one of those topics that is actually rather low yield. The diseases come up on the test a lot, but there are so many of them, and it requires so much memorization that it may just not be worth the squeeze. If you're going for a pass or high pass on your shelf, maybe skip this one. What I'm going to do is cover all of the diseases that you have to know if you're going to cover immunodeficiency, and there are a lot. And so it becomes more about identifying the disease based on the clinical presentation more than it does about making the diagnosis or knowing some random test or treatment. Start off by building our approach to immunodeficiency and then go through each section one at a time. So to talk about immunodeficiency in general, I want to set up a little bit of the immunologic system. That is to say, we have an adaptive immune system as well as an innate immune system. We're also going to have a cellular immune system as well as a humoral. The innate immune system exists, just their sort of general defense. And what you're going to see in the way of cells in the innate immune system are going to be the NKs and the macrophages. They just eat stuff and present antigens. The innate humoral defenses are going to be complement. The adaptive immune system is going to be comprised of T cells and B cells. The cellular mechanisms are going to be T cells, and you'll be able to identify T cells by their CD markers. Usually CD marker 4, 8, single digits and teens, versus the B cells in the humoral immunity, which are going to produce immunoglobulins, antibodies. These are usually going to carry CD markers 40, 50, and above, the double digits. You can already begin to see there's 4 major sections that could break, and each time something breaks, you're going to get a different type of infection. What you can't do is learn what you learned for step 1, where you have a certain cell broken and you become vulnerable to a particular type of pathogen, a fungus, a virus, or some sort of bacteria. Instead, what you have to do is identify either immunodeficiency in general or the very specific disease this child has. So to break that down, to show you an overview of what this lecture is going to look like, if you've got immune deficiency, you're going to have something wrong with one of these cell lines. It could be B cells, T cells, or a combination. It could be a problem with phagocytosis, or it could be a problem with complement. And this is why I said it's probably not worth the squeeze, because as you're going to be able to see, there's a lot of stuff you have to know. In the B cell category, we're going to talk about the X-linked A gamma globulinemia of Bruton's, as well as combined variable immunodeficiency, IgA deficiency, and hyper IgM. We'll compare those and see why these diseases are often tested against each other. The only T cell disease you need to know about is DeGeorge. Don't forget about HIV that does infect T cells, but this is not an immune deficiency that they're born with, it's something they acquire through a virus. In the combined section, we're going to have Wiskott-Aldrich, ataxia-telangiectasia, and severe combined immunodeficiency, which is effectively mega AIDS without the virus. In the phagocytosis, we have chronic granulomatous disease, leukocyte adhesion deficiency, and Shediac-Hadashi. In complements, what we're going to talk about is the C1 esterase deficiency in relation to angioedema, as well as C5 through C9 MAC attack, which is going to predispose you to an infection with Neisseria. But in general, the way you're going to identify a kid has an immunodeficiency is by looking at either recurrent infections because exposure should make them immune, but if they keep getting the same infection over and over and over again, it means something's wrong. They might have severe infections with normal bugs, or they might have unusual pathogens. stuff that you just don't expect them to be infected with. Very similar to taking care of someone with HIV. Or it may be something as simple as a failure to thrive presenting with a diarrhea, and you begin to work them up, not thinking immunodeficiency. But almost always, you're going to see these diseases at greater than 6 months. The reason is because mom donates baby, her antibodies, and they last for about 6 months. So right around the time where baby is supposed to start making their own, if they don't, they'll start getting these weird infections. Recurrent, severe usual, or unusual pathogens tip you off to immunodeficiency. And the workup is generally going to go the same way. You're going to get a CBC. And the CBC is going to come with a diff. So you're going to see the number of white cells, and you're also going to see the percentage, neutrophils, lymphocytes, etc. You may end up getting a quantitative IgG level, which will tell you the values of IgA, IgG, and IgM. And if you recall, IgM is the non-specific version that all cells can make, and then once exposed to an antigen, it then specifies through cellular mechanisms to become the IgA or IgG. After that, it is going to be disease-specific, and is usually not worth memorizing, except for the ones I tell you, because these are the ones that are commonly tested. And the treatment is going to also be disease-specific, but generally the goal is to avoid the pathogens they can't fight, and then also give them what they don't have. I'll start off with B cells and their deficiencies, and we'll move on. The first is the X-linked agamma-globulinemia of Bruton's. The name has the pathogenesis. It is X-linked, and it is agamma-globulinemia. No immunoglobulins in the blood. Because it is X-linked, it is going to affect boys, just as it is a deficiency of B cells. B cells for boys, X-linked for boys. The patient with Bruton's is going to present with immunodeficiency at 6 months, and generally they will have sinopulmonary infections. Because you need to have these immunoglobulins around to defend the natural spot where infections come in. So either recurrent, severe, or unusual sinopulmonary infections. You're going to begin the workup with the CBC, but because this is a problem with B cells making immunoglobulins, it's going to be normal. And likely the test is just going to give you the CBC. It's not going to be, hey, there's an immunodeficiency, pick the CBC. They're going to give you the CBC and then expect you to get the quantitative immunoglobulin. And because it's X-linked agamma-globulinemia, there are no IgA, no IgG, and no IgM. Absolutely absent. Now this is where it's worth knowing a little bit more, because you could get the next test, which will show flow. Flow cytometry will have no B cells. So you'll have a bunch of CD markers that are low numbered, but none higher up. And you can confirm the diagnosis with the RTK gene. Gets very detailed, I know. But the treatment is going to be to give them what they don't have. So you're simply going to schedule intravenous immunoglobulin. You give them the IgG they don't have, they fight infections. And because this is with them their entire life, you're always able to change their marrow with a bone marrow transplant. But that's usually too severe for this disease. If we compare this, though, to combined variable immunodeficiency, what you'll see is that this is just a mild form of XLA. So if you see the kid who's got the recurrent sinopulmonary infections, but is in a teen or older child, they would not have lived this long without getting infusion of immunoglobulins, so it must be a less severe form. You're going to get that CBC, which is going to be normal. And it was going to be the quantitative immunoglobulins that show you a decrease in 2 out of the 3 of the immunoglobulins. Generally, you have something left, and that something prevents them from getting super sick. This is less severe, so you can still schedule immunoglobulins, but generally you don't have to. And certainly you're not going to do a bone marrow transplant for these kids because the bone marrow transplant comes with a high cost and the disease is not so bad. IgA deficiency, again, the name has its pathogenesis. Because there is a reduced IgA, you cannot fight mucosal defenses. And this is going to present in one of two ways. IgA is going to be in the things that are exposed to the outside: ear, nose, throat, and gut. So you may see sinopulmonary infections, or lots of bouts of GI bugs, gastroenteritis. But that's usually not the way the test is going to go. IgA deficiency is usually going to present as asymptomatic until you get a blood transfusion, and then they go anaphylactic. This is not ABO incompatibility. This is not Rh haplotype. This is going to be full-blown anaphylaxis and exposure to a transfusion. You hear that combo, think IgA deficiency. And because it's immunodeficiency, you're going to start with a CBC, but it's going to be normal. And the test will usually give that. And the quantitative immunoglobulins is going to show you, you guessed it, decreased levels of IgA. But there will be increased levels of IgG and IgM, which is why they go most of their life asymptomatic. They're still able to fight infections, they just don't have that IgA around to be really good. And since they're usually asymptomatic, you don't have to do anything to treat it, except, by the way, watch out for anaphylaxis with transfusions. If you see anaphylaxis, treat with epi. But you may need to screen future blood and take out the IgA. The idea is that IgA is a protein, and to a body that cannot make IgA, it is a foreign protein, and so the body will attack IgA. When we take the sample of blood from the donor, we put it into the patient recognizes IgA as foreign and has an immune response. The last one I want to point out to you is hyper-IgM. This shows you just how annoying these questions can be. In hyper-IgM, you have a deficiency of B cells. And the idea is that they cannot convert IgM to IgG. IgM is the non-specific, fights everything. IgG is supposed to be the targeted memory against a particular antigen. If you can't do that, well, you're going to be able to fight infections, but not great. So you're going to have a non-specific immune deficiency. And you're going to start with a CBC, which is going to be normal, and you're going to get quantitative immunoglobulins. Now you can't differentiate, right? This process is broken, so not surprisingly, you're going to have a decreased level of IgG and a decreased level of IgA, but you're going to have a massively increased IgM. The treatment is usually not warranted. The IgM is enough to handle it. 2 out of 3, that's 2 out of 3. And the IgM is really high. So it's hyper-IgM, but there's a lot of IgM, or it could be CVID, but I'm not really sure which one. So you have to memorize a lot of details to get this right. X-linked Brutons is going to be very early on in life, greater than 6 months. Lots of infections, no immunoglobulins. CVID is that same presentation in a teenager. IgA deficiency, look for red blood cell transfusion anaphylaxis. Check the IgA levels, and then hyper-IgM is lots and lots and lots of IgM. That's just the B cells. Let's move on to T cells and combined diseases. There's only one T cell disease you really need to know about, and that is going to be DiGeorge syndrome. DiGeorge is caused by a 22q11.2 deletion. 11 times 2 is 22. 2 times 11 is 22. 22q11.2 deletion. It is a problem of the third pharyngeal pouch, reaching way back to your embryology. The patient is going to present with a very specific syndrome, which is why it's the one that gets tested. The patient is going to have wide-spaced eyes, low-set ears, an absent thymic shadow, that's what you're looking for on an X-ray, and a really small face. And here is where it's true. If you have T cell deficiency, this is where you're going to get infected primarily with fungi and PCP. But usually it's the syndrome that tips you off, not the infection that tells you. The diagnosis, therefore, is clinical. If you have the syndrome, that's all you need. If you get a CBC, you might see a reduced absolute lymphocyte count. Neutrophils are fine, it's the lymphocytes that are the problem. To treat these patients, you're going to put them on trimethoprim sulfa right off the bat, prophylaxis against PCP. They're going to need IVIG, and they're going to need that as a bridge to a thymic transplant. And this is why this is so important to know, even though they are syndromic. Even though they can simply die from infection, if you give them the thymus they don't have, which came from the third pharyngeal pouch, then they do quite well. But also remember what else comes from that third pharyngeal pouch. Watch out for hypocalcemia because of the absent parathyroid hormone. This can present as tetany or seizures requiring you give them calcium. And the advanced organizer behind this is going to be a typical baby face. A little tuft of hair to remind you it's T cells. It's going to have wide spaced eyes, low set ears, and absent thymic shadow. That's a George syndrome, the only T cell disease you need to know about. The combined diseases are super low yield. And so hopefully what I'll show you is to catch the very specific clues that give you the answer for each disease. What do you see in the vignette? Pick out those parts. Diagnosis done. The first is Wiskott-Aldrich. The pathogenesis of Wiskott-Aldrich is X-linked. And just like Bruton's, it'll affect boys. The patients are going to present with atopic dermatitis, eczema, low platelets, and normal infections. Eczema, low platelets, and an immunology question, it's Wiskott-Aldrich. The diagnosis begins with a CBC, where you're going to have a decreased white blood cell count, and of course, low platelets. If you did a quantitative IgG, what you'll see is an attempt of the B cells to make up for it, which is an increase in the IgM, an increase in IgG. The only thing you can do here is a bone marrow transplant. That's the one you have to know the most about on the combines. The other ones get much easier. Ataxia telangiectasia. Guess what that one's about? You guessed it. Ataxia, telangiectasia, and immunodeficiency. Just to be able to identify that combination as ataxia telangiectasia as a disease. And then remember DNA repair, leukemia, and lymphoma. The last combined is the bubble baby, the one that gets a lot of attention in media, but really not attention in life because it's so rare. In severe combined immunodeficiency, you have no immune system. You have no defense. And so the kids are going to be essentially mega AIDS. They have no ability to fight any infection whatsoever, so anything they get exposed to runs rampant. That means no Bs and no Ts. And from way back when, deficiency of adenosine deaminase. The patient presents with immunodeficiency immediately. And any type of exposure leads to an infection. The way I like to remember this is mega AIDS, but HIV negative and no exposure. You're going to make the diagnosis by getting a CBC, which will show decreased white blood cells. And you might get the immunoglobulin quantitative study, in which case you'll have no IgM, no IgG, and no IgA. This person can't live. The way you have to treat them is to isolate them. This is what the bubble baby is about. They must be sealed behind plastic in a completely sterile room and cannot interact with their environment, otherwise they die. You may need to give trimethoprim sulfa as prophylaxis against PCP, but the only chance that these kids have is a bone marrow transplant. If they don't get that bone marrow transplant, they're effectively dead. T cells, DeGeorge, lot to memorize. That's the one I'd pay a lot of attention to. And then combined, recognize that eczema, low platelets, and normal infections is what's got Aldrich, ataxia-telangiectasia, and immunodeficiency, ataxia-telangiectasia, and SCID, every infection under the sun from birth, they need a bone marrow transplant. And yes, I'm doing this on purpose. I am saving the ones that are even lowest yield for the end. We talk about phagocytosis. We're going to talk about chronic granulomatous disease. In chronic granulomatous disease, there's no respiratory burst. It's a problem of macrophages. That is, macrophages are able to phagocytize. They can eat the bacteria, but they can't kill catalase-positive organisms. So the patient is going to present with staph abscesses. And if you see lots of recurrent staph abscesses, you make the diagnosis of chronic granulomatous disease using the nitro blue. Nitro blue. This is probably what you learned in microbiology. That's the thing you want to hang on to. Because these macrophages can't actually kill anything, the rest of the immune system is going to ramp up. The CBC is going to show an increased white blood cell count. And if you got the quantitative immunoglobulins, what you'll see is an elevation in the IgM and the IgG. But it's the nitro blue test that tells you what disease they have. And the only thing to do is to do a bone marrow transplant. Compare that to leukocyte adhesion deficiency. And this is the one where the clinical picture makes it ripe for a test question. Effectively, it's in the name. White blood cells can't get out. They can't leave the bloodstream. They can't get onto the wall in between and into the interstitium where the infection is. So there's going to be a robust immune response. There's going to be high fever. There's even going to be a high leukocyte count. But any infection will have no pus. And here's the thing that you want to look for in the test. Delayed separation of the cord. The neutrophils are supposed to cleave that thing off, but they don't. So delayed separation of the cord, as well as infections without pus, tip you off to leukocyte adhesion deficiency. The only thing you have to know, bone marrow transplant. The lowest yield of phagocytosis, Shiryak-Kadashi. I want you to remember very, very few things about this. There are going to be an autosomal recessive disease if you identify the words giant granules in neutrophils, you have your answer. That's your diagnosis. Also know that it can be associated with albinism, neuropathy, and neutropenia. That's it for the phagocytes. We're going to finish this lecture with complement. What you need to know about complement deficiencies is very limited. I want you to link C1 esterase deficiency with spontaneous non-drug-related angioedema. If you have C1 esterase deficiency and someone develops angioedema, give them FFP. And if someone has an infection with Neisseria, you see Neisseria, you pick C5, C9 MAC attack. You do not have to know anything about that other than Neisseria, C5, C9. Angioedema, C1 esterase. Shiryak-Kadashi, giant granules and PMNs, will be able to identify the toxic patient without a pussy wound and delayed separation of the cord as leukocyte adhesion deficiency, and the nitro blue for chronic granulomatous disease. I told you, low yield, lots to memorize. not worth the squeeze if you're going for the pass. That is peds immunodeficiency.